Good morning, everyone. Welcome to the National Pancreas Foundation's virtual education webinar that will focus today on pancreatic disease in the African American community. We are grateful for your participation and for the support of our local Atlanta Centers of Excellence, our volunteers, and our patient speakers. We would like to acknowledge the efforts of our Atlanta volunteer support team, especially Barbara Washburn and the John R. Lewis Legacy Institute, who have worked hard to help foster a community of support for our African American initiative. The mission of NPF is to provide hope for those suffering from pancreatitis and pancreatic cancer through funding cutting-edge research, advocating for new and better therapies, and providing support and education for patients, caregivers, and healthcare professionals. Some of our featured programs include the Animated Pancreas Patient, our NPF Cookbook and Pocket Guide, our African American Initiative, our Patient Registry, and our state chapters that support education, fundraising, and patient support. Our physician programs include research grants, medical education, and our annual Fellow Symposium. Please reach out to us at info@pancreasfoundation.org with any question or support needs. And before we get started, I would like to welcome NPF's Executive Director, Jenny Pagel-Giles, who will share a few words. Jenny joins us with nearly 20 years of experience in the health charity field. She has worked with healthcare teams, medical professionals, and patient advocates to fundraise and grow mission-focused programming. Welcome, Jenny.
Good morning and hello and thank you, everyone. Thank you, Trish, for helping coordinate today. This is a virtual program, so it allows us to have a broader impact and continue sharing today's information. I'm excited to be a part of the National Pancreas Foundation community as we continue the work of our mission to support all pancreatic diseases. With today's program, we are specifically addressing the critical needs and disparities impacting our African American patients. Thank you to our panelists for leading our discussion and having these conversations. I encourage everyone in today's call to actively participate and contribute. The African American Initiative was created to help change the healthcare statistics within the African American community, but also to educate the community on the signs and symptoms of pancreas disease, and for them to be engaged and empowered in their own diagnosis and healthcare improvements. This initiative also allows physicians to know about pancreas disease as well. And when possible, we are in front of policymakers so we can change the landscape of the pancreas disease funding arena. Trish mentioned several initiatives where you can personally continue to grow your journey with the National Pancreas Foundation, and I encourage you to utilize our resources. We can't do this alone, and we partner with national and local organizations to promote this African American initiative, like the John Lewis group. Those watching, we need your help, and I look forward to meeting you, learning your unique stories, and learning how you have been impacted by the National Pancreas Foundation. Also, a large thank you to our sponsor and partner, AbbVie, for their generous support for programs such as these. Together, we will put an end to pancreatic disease. And again, thank you for everyone for participating and joining us today. I'll turn it back to Trish.
Thank you. So our topic today is pancreatic disease in the Black African American community. Again, thank you to AbbVie for supporting our education programs, especially the African American Initiative. A special thank you to our moderator and panelist, Dr. Maria Russel, surgical oncologist at Grady Hospital's Emory University School of Medicine, Dr. Andrew Page, surgical oncologist at Piedmont Hospital, Whitney Bond, who is our clinical dietitian with Winship Cancer Institute of Emory University, and Dr. Teresa Oh, Pediatric Gastroenterology at Emory University School of Medicine. We also have some patient survivors, Tiona Decree and Thomas Walters. I want to thank you all for sharing on this important health topic. For our attendees, please use the Q&A section of our portal to submit any questions that you might have, and Dr. Russell will field those at the end of today's presentation. Thank you, everyone, and Dr. Russell, the program is all yours.
Great. Good morning. Thank you for having us. Look forward to a great discussion this morning. I'm first going to introduce Dr. Andrew Page. Dr. Page completed his general surgery residency at Emory University Hospital. He then went up to Johns Hopkins, where he completed his surgical oncology fellowship. He then returned to Piedmont Hospital in Atlanta, where he serves as a director of surgical oncology and hepatobiliary surgery for Piedmont Healthcare. He's also the co-founder of the Piedmont Pancreas Cancer Surgery Clinic. Dr. Page is an expert on pancreas cancer, and he is going to talk to us this morning on giving us an overview of pancreas cancer and some statistics. Dr. Page.
Thank you, Dr. Russell, for that kind introduction. Dr. Russell and I have known each other for a while, and I'm not sure why she didn't include more criticisms, but I appreciate the kind words. So my name is Andrew Page. I'm a surgical oncologist like Dr. Russell, where most of my patients have a variety of problems with their pancreas, that is being pancreatitis, which I'm going to talk about, and pancreas cancer. I also see other types of cancers, but this is obviously the focus today is on the pancreas. So what is the pancreas? A lot of people hear pancreas, they hear it on the news, and they just cringe usually when they hear, especially about a pancreas cancer. But let's first talk about what the pancreas does. So the pancreas is an organ that actually sits closer to your back than your front, and it sits behind your stomach. The pancreas has a variety of functions. Where I break it down into two groups of functions: digestion and regulating hormones like your blood sugars. So with those two functions, I think it's really important when we talk a little bit later about when you may have problems with digestion or with your hormones, like worsening of diabetes, why that's important, because that can be an indication that you have pancreatitis, or sometimes it can mean early diagnosis of pancreas cancer. So the pancreas, it's unlike most organs where it's more granular. It kind of looks like solid cottage cheese, is what I try to describe it to most of my patients. And a lot of people, a lot of surgeons don't like taking care of patients with pancreas issues because it can be a more challenging treatment plan if you're not doing it all the time. It's not because a lot of doctors don't want to do it; it's just they're not as comfortable because they don't see those patients as often as the other panelists included today. So, to start talking about pancreatitis, uh, pancreatitis is when the pancreas, itis means it gets inflamed. So anytime that the pancreas gets angry, something insults it, either genetically or with food, some types of foods, or some types of other insults like smoking and alcohol, your pancreas can get angry and inflamed and get the pancreatitis. Sometimes this pancreatitis resolves on its own and you don't really have any issues. Other times it can cause scarring or cysts or other types of issues. And we'll talk a little bit more about the disparity component of that in just a second. So that's pancreatitis. Again, if you have questions, please put them in the chat for Dr. Russell, and she'll direct them to us to address. Then pancreas cancer. So pancreas cancer is different than pancreatitis. So there are a lot of different types of pancreas cancer, but for the sake of keeping things simple today, the most common type of pancreas cancer is called pancreas adenocarcinoma, and that means it's coming from the glands of the pancreas. So as I mentioned before, we talked about the enzymes or the digestion portions, and then there's the hormonal portions or the hormonal functions of the pancreas. So pancreas cancer, unfortunately, is a rapidly tends to be a very aggressive type of cancer. And in the United States now, it's actually the third leading cause of pancreas-related death. By 2030, it's expected to be the second leading cause of pancreas-related death in the United States. And unfortunately for pancreas cancer, 70 to 80% of patients, when they're diagnosed, do not have a curative option. And that's a really staggering number, and we're hoping to improve that. And it actually has gotten a little bit better over the last couple of decades, but that number is really staggering compared to other types of cancers. And, as we've mentioned, the sponsors here from NPF was my good friend, Miss Washburn, and the VG Jazz Group, and the John Lewis Research Group, and the Purple Pansies groups I've worked with many, many times. We all have a similar message when it comes to pancreas cancer, when it comes to the statistics, that number we presented before, where early awareness, early detection is key. So what can we do about that? I have a little poster on my office door that everybody kind of makes fun of me about, and it's basically I say the same 5 things to my patients with pancreas cancer. Again, this is pancreas cancer, not pancreatitis. And that's number 1, don't smoke. Number 2, don't drink. Number 3, know and ask your family history. And we'll talk more about the disparities, I know, as the conference goes on, but that seems to be a recurring theme for pancreas cancer, is that especially in the African American population, many patients don't know what their family history is, specifically in regards to different types of cancers, especially pancreas cancer. Now, I'm not African American, but I even asked my grandparents many years ago about their family history of pancreas cancer or any other kinds of cancers, and they didn't know. And then even just a couple of years ago, I asked my mother if she knew about her family history, and she also had a pretty limited understanding. So that's number 4. And then the last one is, again, early detection is key. We've got to have earlier awareness, and that comes through conferences like this. And we need to really push it with our primary care physicians. And I think that has been a barrier that we're, as surgeons that take care of a lot of pancreas cancer patients, we're slowly chipping away at. But that's really, really critical from the primary care community, is to really help them understand when something isn't right. You probably need to get a scan to see if there's something brewing in the pancreas. So again, I want to repeat those 5. 1, don't smoke. This is to decrease your chances of getting pancreas cancer. 1, don't smoke. 2, don't drink. Know and ask your family history. Be your best advocate, because again, doctors are not perfect. Dr. Russell and Dr. Oh are probably pretty perfect, but I'm definitely not. So really keep that in mind, that doctors are not perfect. And then 5, early detection is key. So let's talk about the disparities with in the African American community in terms of pancreas cancer, and then we'll flip back to pancreatitis in just a second. Pancreatitis is actually a little bit behind in the literature, so that will be a pretty brief review that I've prepared. So in the African American population for pancreas cancer, let me turn my notes here. One of the most well-established statistics in pancreas cancer in the African American community is that African Americans are more likely to be diagnosed with pancreas cancer, and they're also more likely to die from pancreas cancer. That hasn't changed much in the last 10 to 15 years. Now, fortunately, rather, there actually has been a very pretty depressing and frustrating number that the treatment planning for patients, for African American patients with pancreas cancer, had not been equivocal to the Caucasian population. And that's been well established for 20 to 30 years. But recent data from the CDC, that's called the SEER database, shows that those numbers are actually getting better. And one number that really had bothered me, that when my training I had been exposed to, was that the number of African Americans being offered surgery for their cancer was disproportionately lower than in the Caucasian population. That number, and I say this with optimism, has actually started to level out. So that's actually a very positive and encouraging factor, that because of conferences like these that we need, I think, even more of, that number is improved. So there's that hopeful optimism. Second is the timing from diagnosis to therapy. So say someone is diagnosed with pancreas cancer, the time that they start their therapy historically has been greatly discordant in the African American population compared to the Caucasian population. But also, encouragingly, that number has started to improve. Again, a testament to why grassroots community involvement, like conferences like these, is important. I have a lot of more statistics, but I want to kind of shift gears just real quickly to pancreatitis in the African American population. Again, there's not as much real prospective data or large meta-analyses that we talk about, which are just basically big studies looking at differences in the management and treatment of pancreatitis in the African American versus the Caucasian population. But pancreatitis in general it does result in a lot of costs to patients and the medical system. But compared to the Caucasian population, African Americans are actually, their pancreatitis tends to be more causative secondary to alcohol compared to the Caucasian population. So I think there's a theme that I've kind of alluded to but have not explicitly said, in that I believe that the genetic components of a lot of these tumors and the responses of our own host immunity in the African American and the Caucasian population is different. And I think that is even more evident in chronic pancreatitis, because it seems like the alcohol tends to be more of a driver for pancreatitis in the African American population than the Caucasian population. Additionally, we call morphological abnormalities, or calcifications, scarring, pseudocysts, and strictures within the pancreas tend to be more aggressive in the African American population compared to the Caucasian population as well. And the pain, using a variety of different scoring methods, tends to be more severe in the African American population as well. So without getting too in the weeds, I do want to come back to my 5 really, I think, critical points. There's don't smoke, don't drink, know and ask your family history, be your best advocate. Doctors are not perfect, and early detection is key. So do want to end with one interesting component specific to disparities in the management of cancer that I came across, which related to smoking. And I'll just read this from this CDC statement. I apologize. According to the CDC, African Americans are less likely to smoke and are more likely to start smoking later than Caucasians. So they're less likely to smoke, but they'll also, if they do smoke, they smoke later. Yet they are more likely to die of smoking-related conditions and have higher rates of smoking-related cancers. So there's obviously a problem here, and we need to do everything we can to, we've started to show some progress, but statements like these from the CDC about smoking-related cancers demonstrate that there's still a significant issue, and we need to do everything we can. And I think, again, forums like this are a really, really great start.
Fantastic. Thanks, Dr. Page. There's been some questions that popped up in the chat. We'll address these at the end. We'll let you handle those at the end, if that's okay.
Sure.
All right. So next, I'm going to talk about the treatment. Now that he's given you what happens and how you're diagnosed with pancreas cancer, I'm going to give an overview of some treatment. I'm not as good as Dr. Page. I have to have some slides to remind me about what I'm going to talk about. So we'll go through these really quickly. As Dr. Page mentioned, it's really important to distinguish the type of pancreas cancer that you're talking about. So the 2 main types of pancreas cancer are pancreatic adenocarcinoma and pancreatic neuroendocrine cancer. So pancreatic neuroendocrine is what Steve Jobs had, for those of you that remember his story, and that has a much better prognosis. And so for purposes of today, we're going to focus on adenocarcinoma. So what happens when you get first diagnosed with pancreas cancer, your family member or loved one gets diagnosed? There is a certain number of tests that you have to go through so that we can find out important information about your tumor. Number 1, where is the tumor located? Is the tumor localized to the pancreas, or has it already spread to the liver, lungs, peritoneum, or elsewhere? As Dr. Page mentioned, and I'll show some statistics in a moment, that over half of patients present with metastatic disease, and even more than that are unable to undergo curative intent surgery. Are the ducts enlarged? Do you need other procedures done before you can get started with treatment? And then finally, is the tumor resectable? Will it eventually be able to be cut out? So some of the tests that you might undergo, everyone needs a CT scan of their chest. This is, again, to rule out metastatic disease in the lungs. And then everyone gets abdominal imaging, and that can be a CT pancreas protocol. It can be an MRI. A lot of these are, some patients will get both of these, but a lot of these are clinician dependent. I personally like CT scans over MRIs, but sometimes we'll get an MRI for further clarification. Patients are going to go a host of laboratory tests, including chemistries, CBCs, INRs, And then we're obviously going to check tumor markers. The two that we check for pancreas cancer are CEA and a CA19-9. And the CA19-9 has important implications. If it's super high, we start to worry that maybe there's spread of the pancreas cancer, but it also gives us a tool to monitor response to chemotherapy or to radiation. And hopefully that number goes down and approaches normal, which would be a really good indication that the patient is responding to the treatment. And then finally, I'm going to look at this diagram right here. As you can see here, this is your liver. This is the pancreas. As Dr. Page mentioned, it sits right on your aorta and closer to your back than your front. This is the bile duct here in green, and it drains the liver and it drains into the duodenum. This here is your gallbladder. And so oftentimes when we're talking about pancreas cancer in the head of the pancreas, which we'll get to anatomy in a second, we're talking about it in this area, and it can actually block these ducts. That's why patients often with pancreatic head tumors will come in with yellow eyes and yellowing of the skin called jaundice and scleroicterus. And so if the bilirubin is elevated, patients will often need an ERCP and a stent to lower the bilirubin, not only for nutritional and immunologic assistance, but also because we can't give chemotherapy if patient's bilirubin is too high. Everyone wants to know what stage they're in with pancreas cancer. There are two types of stages. One is a clinical stage which Dr. Page and I use to stage patients when they first come in to decide on what kind of treatment they should have. This is the NCCN guidelines where you look at the T stage, referring to the primary tumor, the N stage, and the M stage. So T and M staging, and you can see down here what stage you are. So while this is important, I would also want to introduce some other really important terms that we use when trying to figure out what treatment we're going to use for our patients. Resectable refers to, is the tumor able to be cut out? In other words, is it free from all blood vessels, and is it able to be removed safely? Next is borderline resectable. That refers to tumors that may involve blood vessels, but after treatment, the hope is that the cancer can be cut out, or we can reconstruct those blood vessels. Locally advanced means that the tumor is more advanced, but not metastatic, meaning it may involve multiple blood vessels, may have some lymph nodes that are right near, but those typically tend to be more advanced, encasing blood vessels, sometimes multiple ones, and that cannot be cut out without a very good response to chemotherapy. And then finally, metastatic, again, refers to when the tumor leaves its primary place where it starts, which is the pancreas, and goes someplace else. So when it goes to the liver, it doesn't change to liver cancer. It's still pancreas cancer in the liver. When it goes to the lung, it's not lung cancer, it's pancreas cancer in the lung. And that is unresectable cancer. In other words, we do not operate on that. There are three pillars of treatment for pancreas cancer: chemotherapy, radiation, and surgery. And then who gets what treatment? This is, Dr. Page mentioned the SEER database. This is the SEER database, which was accessed yesterday. And so this gives the most up-to-date numbers. And unfortunately, as we've already discussed, 51% of our patients present with metastatic disease. There is no cure for this cancer. That means it is spread beyond the pancreas, and the mainstay of treatment for these patients is going to be chemotherapy. Next, you have about 30% of patients that present with local regional nodes. Some of these will be able to be resected, and some will progress while they're on chemotherapy. The treatment for regional disease can be chemotherapy. If there's a decent response or no progression of disease, those patients may ultimately become candidates for radiation and or surgery. And then finally, 13% of patients present with cancer that's localized to the pancreas, and those patients should get at least chemotherapy and surgery, plus or minus radiation. It would be extraordinarily rare that anyone just got surgery in this day and age for their pancreas cancer. So when we used to see a resectable pancreas cancer, we would take them straight to surgery, give the patients chemotherapy postoperatively, plus or minus radiation. In the last 10 to 15 years, since Dr. Page and I have been practicing, what we have done is actually change that sequence of treatment, such that patients right now are getting chemotherapy up front. Most of my patients, if not all, get chemotherapy up front, plus or minus radiation, and then surgery. We'll talk a little bit more about that. So as a patient, you would want to know why chemotherapy first. Everyone wants their tumor out. They are scared. They, know that pancreas cancer is aggressive, and they just want us to take the cancer out. Well, the problem is that even if Dr. Page and I do a perfect operation, we get all the lymph nodes, we get negative margins, patient does great with surgery. Unfortunately, this is a very aggressive type of cancer that has a tendency to recur. But even if we do a perfect operation, the chances that it recurs here where we took out the tumor, or in the tail of the pancreas where we took out the tumor, the chances that that's going to reoccur in that area are somewhere between 25 and 35, maybe 40%. That means the majority of the cancers, when they recur systemically. They recur in the liver, in the lungs, in the abdominal cavity. And so what we have come to know is that pancreas cancer is really a systemic disease. It's not just a local problem. And so for these reasons, we tend to now recommend chemotherapy first. Tumors do a great job of making new blood vessels and making sure that the tumor is well fed. And so we can use those new blood vessels to deliver chemotherapy before the surgeon goes in and mucks around with the blood flow to the tumor. It allows evaluation of the tumor so that we can see what chemotherapy actually works. We can see the tumor response. It treats any microscopic disease that the patient may have. It also gives us some time to make sure that the tumor is not spread and that surgery will be useful. When Dr. Page and I are doing these operations, these are big surgeries. They're very big deals. And while I would submit that we love to operate, we really only want to operate on patients that we have the chance to help. And then finally, if we had a crystal ball that told us who was going to go through surgery and have 0 complications and get to chemotherapy right at 6 to 8 weeks post-surgery, it may be reasonable to do an operation first. Unfortunately, that's not the case. These operations have a high risk of complications, and the complication will delay or maybe even prevent the chemotherapy from being given. And remember what I said, pancreas cancer is a systemic disease and everyone gets chemotherapy. So moving into the chemotherapy regimens, there are 2 main regimens that we use currently. One is FOLFIRINOX and the other is gemcitabine and Abraxane. FOLFIRINOX is the first chemotherapy regimen that's actually been demonstrated to have a radiographic response. So when we're looking at the tumor on your subsequent scans after your initial scan, after you've gotten some chemo, what we can see is shrinkage of the tumor and some response, which is really nice. The only problem is that this is a really toxic regimen. We don't, patients have to be really healthy. Most young patients who are really robust will be offered this, but it's not really appropriate for patients that are struggling a little bit with malnutrition. Maybe their diabetes is out of control. Maybe they, are not as active as they could have been, if they didn't have cancer. And so for those patients who are a little bit more frail, we tend to give gemcitabine and Abraxane. That's not to say gemcitabine and Abraxane doesn't work. I've actually had patients that have gotten FOLFIRINOX and not responded and then gotten Abraxane and actually done quite well. And so we don't quite understand exactly who should get what chemotherapy. But if you're young and healthy, you're going to get FOLFIRINOX. And if you're more frail, you're usually going to get Abraxane. FOLFIRINOX is given every 2 weeks. We usually re-image after 2 months of chemotherapy to see how patients are responding. Abraxane is given once a week for 3 weeks and then a week off. And again, the medical oncologists are managing these chemotherapy regimens, and they may make changes to these. Next is radiation. Neoadjuvant just means that we're giving the radiation before surgery. We can give that in an attempt to shrink the tumor away from the blood vessels, to quote, sterilize the edge of the tumor as we're scraping the tumor off of those blood vessels if we aren't going to resect them. Adjuvant chemotherapy is sometimes given if the patient hasn't got, radiation therapy is sometimes given if the patients haven't received neoadjuvant radiation and they have a high risk of recurrence, such as a positive margin or a lot of nodes that are positive. And finally, in those patients who have locally advanced, remember I said that's where the cancer is involving multiple different vessels and we can't safely get out the tumor. Those patients may get definitive chemoradiation, which actually has some really promising results for patients where the cancer hasn't spread and is just localized but not able to be surgically removed. Finally, as Dr. Page mentioned, only 20% of patients diagnosed with pancreas cancer are actually eligible for surgery. Without surgery, there is not a cure for pancreas cancer. And so that's why patients with metastatic disease, we say, cannot actually be cured. I do want to go over one myth that we sometimes hear as surgeons. Patients are really nervous. They're afraid to get cancer surgery because they're afraid that the air is going to spread the cancer. And I want to just look at that really quickly with this little diagram that I made. So, here's your pancreas. You have a tumor here in the head of the pancreas, or the unsnip process. And you have these, imagine that you have these little tumors in your liver, all right? You can see these, but sometimes we can't see them because they're too small to be seen on imaging. And so what happens is we give you some chemotherapy, but then we stop your chemotherapy to give you a break before we operate on you. And then you're off chemotherapy for somewhere around 12, 14, 16 weeks or more. And during that time, the chemotherapy is no longer treating these micro metastatic diseases. And what happens is that those tumors start to grow. And so you get your first post-operative scan, and now you have these tumors, which were there all the time, are now able to be visualized. And so it's important that it's not the surgery that makes the cancer spread. It's the inability to detect cancer early enough, in my opinion. So let's talk a little bit more about the anatomy of the pancreas. You have head pancreas tumors. Pancreatic head is here. So tumors here tend to present with jaundice, or that yellowing of the eyes and the skin. You have tumors in the body and tail, and these are treated differently. So I'm going to quickly go through a Whipple operation. These are done for tumors of the pancreatic head. So this is your esophagus. You swallow food, it goes into your esophagus, down into your stomach, and then into your duodenum. This is your bile duct coming from your liver, which is here, and your gallbladder right here. And what happens is the duodenum and the pancreas actually share a blood supply. So it's impossible for us to take out this part of the pancreas and leave this part of the duodenum. That's called a duodenal sparing pancreatectomy. It doesn't work so great. And so we tend to take all of this out together. And so what that means is we have to take a little bit of the stomach. Some people divide the duodenum in instead of the stomach. We have to take the pancreas, the head of the pancreas out. We take the bile duct, and then we take the entirety of the duodenum and the gallbladder. So this is what you're missing after a Whipple. And then we do reconstruction, where we reconnect the pancreas to the small intestine, the pancreas to the bile duct, and the pancreas to the small intestine to the bile duct, and the stomach to the small intestine, so that patients can continue to eat and drink, and drains their pancreas and their liver. A distal pancreatectomy and splenectomy is what we do for pancreas tumors of the tail of the pancreas. What we do is usually divide the pancreas a couple of centimeters before you get to the tumor. We also take the vessels here that go to the spleen, as well as all of the lymph nodes here. And this is why, because we're taking these vessels, this is why for pancreatic adenocarcinoma, we recommend a distal pancreatectomy and a splenectomy. You can do spleen-sparing pancreatectomies. That's not usually done for adenocarcinoma. I do want to mention another important aspect of treatment for pancreas cancer, or clinical trials. The African-American population is very underrepresented in clinical trials, and it's important to know because this identifies new treatments for cancer. Immunotherapy, targeted therapy, vaccine trials, improved ways of accessing the pancreas for more effective treatment. And if we don't know how different patients of different races react to the different types of treatment, then we may end up giving patients treatment that's not applicable for them. And so I think it's really important that, standard of care for pancreas cancer is really important, but it's also important that if you're progressing, maybe you consider going on a clinical trial to see if there's other drugs that may benefit you. I looked this morning, clinicaltrials.gov is how you find these pancreas cancer trials. There are currently 4,200 trials in the United States that are open. And then finally, I do want to talk a little bit about disparities in pancreas cancer. Dr. Page mentioned this. This was a manuscript that was published back in 2021, looking at guideline concordant cancer treatment for patients with pancreas cancer. So guideline concordant care just means that you're getting the care that is recommended by the NCCN guidelines, that you're getting the chemotherapy, you're getting the radiation if needed, you're getting surgery if needed. And I want to focus here on the stage 1 patients. So these are patients that should be getting chemotherapy and surgery plus or minus radiation. And what we see here is a staggering almost 40% of patients are getting no treatment. And patients, only a little over 40% of patients are actually getting surgery. And then you look at the chemotherapy rates, which are really low. And so these numbers are quite concerning for us. When we look at lack of treatment and lack of surgery, they are secondary, sometimes patient risk factors. Sometimes patients come in and they're just too sick to undergo surgery or too sick to even get chemotherapy. But sometimes there's a refusal on the part of the patient or the family to get the treatment for the pancreas cancer. And those, I think, we don't understand exactly why that happens. It's actually an interest of mine to figure out why patients are refusing to get any treatment. We should better understand that so that we can address that. When you have gaps in guideline concordant care, patients that are older, female, African American, and sicker patients, those are who are really experiencing these gaps in guideline concordant care. And so I think, in my opinion, this is definitely an area for improvement. When we look at refusal of surgery, so again, an NCDB is a National Cancer Database. It captures about 70% of cancer diagnoses in the United States. So it's a huge amount of patients. And this looked at early stage pancreas cancer patients. And just to show you what I'm talking about. So overall survival, you want to be up here. This is 100% survival. Okay. And the time since years in diagnosis, what you can see is patients who have early stage cancer and undergo surgery do much better than those patients who are refusing surgery. So these are patients who are offered surgery but refused. And just to hash that out just a little bit more, again, patients who get chemotherapy and surgery in this blue line, they're doing much better than everyone else, okay? So these are patients that are just getting surgery alone, so still big bang for the buck with surgery, but surgery and chemo is really where the higher levels of survival are. These are patients that are getting chemotherapy alone, and if you get no treatment, your survival is less than a year. Right, so this is for early stage, potentially curative cancer. Again, when we look at patients who are refusing surgery, older, female, African American, Medicare, and care at a non-academic community hospital. And so these are areas, again, we need to better understand this patient population. So take-home points for pancreas cancer, it's an aggressive disease. Out of 100 patients diagnosed with pancreas cancer today, in 5 years, 12 of them will be alive. Only 20% of patients who present with pancreas cancer are eligible for curative intent treatment. Dr. Page mentioned some ways that we can hopefully make some progress in this. Patients who have a family history of pancreas cancer are actually eligible for early screening. And so that can identify pancreas cancer early. And again, sometimes it's a very sneaky cancer and can present without symptoms until late. Treatment should consist for early stage patients of chemotherapy and surgery, plus or minus radiation. Curative intent always involves surgery, and we need to understand why treatment is not offered or refused in certain patient populations. I'm going to speak a little bit on treatment of pancreatitis. Again, there are three main types of pancreatitis. Acute pancreatitis, mainly this is supportive care. IV fluids, nutritional support, pain control. I think Dr. O is going to speak more to this shortly. Additional treatment will depend on the cause of pancreatitis. If it's from gallstones, you may need an ERCP that we already talked about to unclog the duct, a sphincterotomy to make that opening into the small intestine bigger, and possibly stent placement. And then patients who have gallstones need their gallbladder out so that it doesn't happen again. If it's from drugs, hypercalcemia, anatomic or alcoholic pancreatitis, usually the treatment is supportive. Occasionally patients get necrotizing pancreatitis, which is a really, really aggressive, high mortality, lots of condition that actually may require surgery or drain placement, but that is a very big deal and should be taken on by surgeons who actually do this kind of surgery frequently. And acute pancreatitis can develop into chronic pancreatitis. You can also get pseudocysts, which require drainage. Autoimmune pancreatitis is a little bit of a very special type of pancreatitis. It often mimics, I know Dr. Page has seen this as have I, comes in and you think that maybe patients have pancreas cancer, and we're always relieved to find out it's autoimmune pancreatitis instead. but it can be difficult to distinguish. We can send some blood levels, some IgG4 levels, which may help us, but is not 100% by any means. Patients may undergo biliary stenting, which we discussed. These patients actually get steroids, but it's really important that you make sure that it's not pancreas cancer, because given a pancreas cancer patient, steroids would be a really bad idea. And then you may need immunomodulation as modulating agents as well. And then finally, chronic pancreatitis, lifestyle changes. Smoking is often unappreciated as a cause of pancreatitis. So when my patients come to see me and they have pancreatitis, there are lots of education that they got to stop drinking, but also smoking. Diet is important. Pain control, also important. And then sometimes you can have surgery to remove, bypass or remove ducts. And then occasionally patients will get total pancreatectomies with islet transplant. We already talked about a Whipple. This is called a Pusteaux procedure, where you have a head of the pancreas that's completely calcified and stenosed, and the duct is really large and painful. And so we can hook that up to the small intestine. And then we have a Fry procedure, which is similar to Pusteaux, but you core out the head of the pancreas as well. So these are pretty rare operations. We try to exhaust non-operative measures for pancreatitis before taking patients to surgery. And again, they have to be very select populations. They can't be drinking. Patients can't be smoking. They have to be good operative candidates. And so treatment of pancreatitis, supportive care, pain control is important. Diet and social habits that are modifiable may contribute to it. And surgery is usually reserved for necrotizing pancreatitis at the very, very, very sick patients who can't be managed otherwise, and then complications from inflammation. So that is the treatment of pancreatitis in, I think, 15 or 20 minutes or less. And now it is my great pleasure to introduce Whitney Bond. Whitney, I have the pleasure of working with at Winship Cancer Institute, where I spend about 70% of my time. And she is just fantastic. Whitney graduated from Clemson University, and she completed her dietetic internship at the University of North Carolina at Greensboro. And she's going to talk to us today about nutrition and pancreas disease. Whitney, thanks so much for joining us.
Thanks, Dr. Russell. Thanks for having me. I'm going to talk to you guys a little bit about diet. So let me just get my slides here for us. The first thing I'll say about nutrition when it comes to the pancreas, and nutrition for anyone, honestly, is that it is really geared towards the patient or towards each individual. Especially when we're thinking about pancreas cancer, one person might have a list of symptoms that another person might not. So, what I'm going to go over today is pretty general. But if you are having, like a lot of diarrhea, then your nutrition regimen might have to be tailored a little bit. And so that's where I think it's really important for patients to really see if there's a dietitian at their facility, because that dietitian will be able to kind of work with you one-on-one and figure out what options might work best for you. So the key trademarks of a diet, this is for pancreatic disease prevention, but also survivorship. Like I said, if you're not having a lot of, crazy symptoms, you want to decrease your saturated fats, your added sugar, and processed foods. You want to increase your fruits, vegetables, whole grains, and lean protein. You guys have probably all heard these things. They're not anything that is, out of this world, but can sometimes be hard to know what exactly that means. So I'm a visual person. I always like to kind of think pictures always help me. So if we're thinking of what you want your plate to look like, these are kind of the main food groups that you want to focus on: your fruits, vegetables, grains, protein, and dairy products. I have a lot of patients ask me if they have to avoid dairy products, and the answer is no. Unless you have some issues with like a milk allergy or lactose intolerance or something like that, it could be helpful for you. But for the general population, dairy can be a really good way to get in some good calories, protein, a lot of good vitamins and minerals as well. So these are the main food groups that we'll talk about. So let's talk about grains, especially for patients that have issues with blood sugar control. a lot of people will ask me if they have to completely avoid, carbohydrates, grain products, things like that. The answer is also no. However, you do want to try to make half of your grains be whole grains. What I mean by that are, your things like rice, breads, pastas, oatmeal, crackers, trying to make them whole grain. So I have a little diagram here of what kind of a snapshot of what a grain looks like. So when we're talking whole grains, you would get everything that is in this picture. So there's three kind of subsets: the germ, the endosperm, and the bran. The germ here at the bottom is where a lot of your B vitamins are, which are helpful for multiple different things in your body. The endosperm is kind of where your like carbohydrate portion is. And then the bran here on the outside is where a lot of fiber is. So fiber is really good for blood sugar control. If you're having issues with maintaining your blood sugar, fiber can be a really good way to regulate that. Some people might be on a lower fiber diet if they are having a lot of problems with like bloating or diarrhea, certain things like that. You might need to be on a fiber restricted diet. But for the general population, fiber is super, super good for digestion and blood sugar control. So a whole grain would be all three portions. That's things like brown rice, whole grain pastas, whole grain breads, things like that. If you are choosing not whole grain products, so things like white rice, white breads, white pastas, that is the only portion of the grain that they use for that is this endosperm here. So you would be ridding yourself of the B vitamins from the germ and the fiber from the bran. And that is why we really try to focus on getting more whole grains because it's just a more nutrient dense option. So let's talk about fats. When we are thinking of, pancreatitis and pancreatic cancer, a lot of times fat can be kind of like the enemy. And we'll talk more about enzymes and things like that on the next slide. But not all fats are bad. There's a lot of good things about good heart healthy fats, but a lot of times, people just don't know what that is. So the type of fat that you want to limit is going to be your saturated fat. That's the type of fat that are in things like fried foods, greasy foods, butter, lard, coconut oil. Mostly your animal-based products typically have more saturated fat. Your unsaturated fats are going to be like those heart healthy fats. So like have a lot of good cholesterol and things like that. So that type of fat are in foods like fish, olive oil, and avocado. So a good thing that to kind of help me as I was going through school to kind of figure out the difference, and I think could be really helpful for patients, is whatever the product looks like at room temperature will kind of be able to tell you if it's a saturated fat or an unsaturated fat. So I have two pictures here. We have the butter. Obviously, butter at room temperature is a solid, meaning that it's a saturated fat. And then olive oil at room temperature is a liquid. So it is an unsaturated fat. So basically, that is kind of what happens in your bloodstream. The saturated fats will collect, and that is what can cause, different blockages with your like blood vessels and arteries and things like that. Whereas the olive oil will like move freely in your bloodstream, which is why it is a more healthy fat. So, if we're thinking of like whenever you fry some bacon, the oil or the grease, if you leave it sitting in your pan too long, will solidify, meaning that it's a saturated fat. So I think that's a good way to kind of gauge what type of fat, we're working with. So let's talk about pancreatic enzymes. So like Dr. Page mentioned, one of the big functions of the pancreas deals with digestion. Basically, one of the big functions of the pancreas is that it releases enzymes into your digestive tract so that your body is able to properly digest and absorb the foods that you're taking in. Enzymes, we have enzymes for all of our food groups. When we're thinking about enzymes, they mainly work on carbohydrates, protein, and fat. And we have enzymes that are released from various different spots in our bodies. So, a lot are released like in the saliva in your mouth. That helps with like carbohydrate digestion. You have a lot of enzymes that are secreted in your stomach that helps with protein digestion. So the enzymes that come from the pancreas do work on all of your foods, but it's the primary release of enzymes that help with your fat digestion. So if that's not happening the way that it needs to, you can see issues with like bloating, cramping, gas, like right after you eat. It could just feels like your stomach is blowing up. And then changes in your bowel movements, like they can be kind of like a pale color. They can be oily, so kind of have like an oily sheen on top of the surface of the water. And then the bowel movements will float on top of the surface of the water rather than sinking to the bottom. And another thing is that a lot of times they will smell like abnormally bad. And the reason why is because your foods are just sitting in your digestive system and aren't able to like fully be processed. So a lot of times patients can have like a lot of weight loss because, you could eat all the nutrition in the world, but if your body's not able to properly take it in, you're going to lose weight. So they'll have a lot of weight loss. And then they'll have a lot of fear when they eat too, because if you have pain every time you want to eat, that obviously every time you eat, that doesn't really make you want to eat. So a lot of times people will notice that they have more issues when they do eat something like fried foods, or even when they eat, something that has some olive oil, or something that has, things like bacon or like creamy sauces. Things like that typically cause more pain versus, just some like plain crackers or something like that, because that doesn't have quite as much fat in it. So fat is not the enemy, but you do want to make sure that you have the resources that you need to digest it properly. So that's where pancreatic enzymes can be really helpful. There are oral pancreatic enzymes that we can prescribe for patients. And so basically what happens is you take a capsule of pancreatic enzymes. I have some people, who are taking 2 or 3. Whenever you eat, and it's really important that you take it every time you eat, because what we want to happen is the enzyme and the food to hit your digestive system at the same time, or it won't work properly. And it kind of depends on how much fat is in the meal that you're having. So if you were eating, like a snack of like a piece of fruit, you might just need one enzyme, or you might not have to take any enzymes at all, versus if you're going to eat something that's like an actual meal, you would likely need more enzyme. So sometimes there's some cases where patients have to be on a lower fat diet for a certain amount of time, but largely patients do not need to be on a low fat diet if they're taking pancreatic enzymes appropriately. A lot of times I'll see patients on really, really small doses of pancreatic enzymes. And I always like to mention that because there are different doses that start with like a children's size dose. And so a lot of times I'll see my adult patients on a children's size dose, and they don't understand why they're taking enzymes, but it's not working. And so a lot of times, working with your healthcare team to make sure that you're on a proper dose can be super, super important for making sure that you're having proper digestion and that it's working correctly. Okay, let's talk about sugars. Sugars or carbohydrates, I think, definitely get a bad rap. I don't think that all sugars are bad, but you just want to make sure that you're avoiding added sugars. So I included a picture of a nutrition facts label. I have a lot of people tell me that they are confused about nutrition facts labels, which it definitely can be confusing with like the percentages and grams and everything. It can just be confusing. So they did update the nutrition facts label pretty recently to include a line that says added sugars, which I think is super helpful. So whenever you're thinking about sugars or you're looking at a nutrition facts label, like say it's a box of cereal, there can be a lot of added sugar in the cereal aisle. So it would be important to look at the line here that says added sugars. Honestly, the percentages on anything on a nutrition facts label isn't that as important. It's mainly more important to look at the grams and milligrams and, fiber. Those are important, not necessarily the percentages. So typically you want the added sugars to be in single digits. 10 or less is kind of a good rule of thumb when it comes to, your products that are going to have more added sugar in them. So like I said, that's typically things like cereals. Obviously, your sweets like cookies, cakes, candies, those are going to be added sugars as well. So when we're thinking of carbohydrates, we really want to focus more on those whole grains like I was talking about previously, and not things like added sugars. Okay, so what to do when eating out? I get this question a lot. Obviously, we are not people who, we're on the go, we're doing stuff. We just need to eat something really quickly. We pull in to a fast food restaurant. What am I going to get that's something that can be helpful? So I think the biggest things to focus on are avoiding fried foods. So most restaurants have options that are grilled or baked. So like a grilled sandwich or something like that would be better than like a fried sandwich. You want to choose a whole grain option if it's possible, specifically with like, your buns of things, or if they have like a brown rice option over a white rice, like that is something that you could choose instead. That, sometimes it's a little bit of a taste difference, but a lot of times it can be just training our taste buds to get into the habit of having things that we haven't had. And so that takes a little bit of training. You want to think about the sides. A lot of times, people's downfall can be the sides and beverages. I didn't include that, but beverages can be a really a huge source of added sugar that a lot of my patients, when I'm talking to them, they're doing, pretty good, but then having a lot of added sugar when in the beverages. And then consider your portion size. Here in America, our portion sizes are quite large. So it can be helpful, if you are eating out, maybe splitting half of the meal, and then that'll give you 2 meals anyway. So then it can be helpful, so that you already have a second meal. But just definitely consider your portion sizes. And then the condiments and the creamy sauces, those are a huge source of saturated fat, sodium, which is sodium you want to avoid for like blood pressure and things like that. That's going to be your salt. So those are some tips and tricks when you're eating out, like kind of what you can kind of be thinking about if you are, at a restaurant or whatever. So I thought it would be helpful to kind of compare some menu items from some different restaurants to just get a gauge of the difference in what your choices can make. So here, the first thing we have here is just a Chick-fil-A fried sandwich and fries compared to a grilled sandwich with the fruit cup. So if we're looking at it, honestly, the calories aren't that much different. You have 420 in the fried sandwich and 390. That's not that much different. However, when we're thinking of the fat, there's significantly less fat in the grilled sandwich than the fried, and the saturated fat. It still has 2 grams, but I mean, that's better than 3.5. So the protein's about the same. Something that is really important here is the sodium. So like I mentioned, sodium is bad for heart function. It's bad for like blood pressure, and if you have like hypertension and things like that. So the grilled sandwich has about half the amount of sodium as the fried sandwich, which I feel is like pretty significant. So, and then with the sides, the fries, those are going to have 420 calories, 24 grams of fat, and 4 grams of saturated fat, whereas your fruit cup has 70 calories and no fat. And you get the good benefits of having the fiber and the different vitamins and minerals that are in your fruits. Typically anything that comes from the ground, so like fruits, vegetables, those are really good cancer fighting foods because they have different nutrients. So, even aside from not getting the fat or saturated fat from the fruit cup, or if you're choosing the fries, you're getting the fat and the saturated fat, and you're ridding yourself of the opportunity to have more cancer fighting foods. So that's Chick-fil-A. Okay, McDonald's, let's talk about the beverages. So I'm not telling you that you can never go to McDonald's or that you can never have, a beverage that you like, but I think it's just helpful if that is something that you're having every single day, just to gauge what you are actually putting in your body. So if we're looking at an iced French vanilla coffee from McDonald's that has 200 calories and 20 grams of added sugar, versus if you were to just get an iced coffee, something that's important is that you have to specify that you don't want any syrup. A lot of places will automatically add sweetener to stuff unless you say that you don't want it. So this is an iced coffee with no syrup. And this is still with like a little bit of cream. And it has 80 calories and 0 grams of added sugar. So that is a big difference when it comes to, what you're putting in your body at the beginning of the day. Not to say you can't have coffee, but just kind of think about what you're putting in it that would maybe, not be quite as nutrient dense. And then at home, I'm the type of person that is always trying to cook really quickly, like quick meals at home. And typically when we're thinking of quick meals, we're thinking of frozen foods. Frozen foods aren't all necessarily bad, but typically anything that stays longer on the shelf or like in the freezer, typically we'll have some kind of additive to make sure that it can last longer. And most oftentimes that is going to be, things like added sugar, things like added sodium or added fat, just to make sure that it can, withstand longer amounts of time. So if we are thinking of some frozen chicken tenders that has 630 calories and 30 grams of fat and 6 grams of saturated fat, versus if you were to choose essentially the same thing, it's just not a fried option, it's your grilled chicken tenders. It's a little bit cheaper and it has half the amount of saturated fat with 3 grams compared to 6, about half the amount of calories and about half the amount of fat. So kind of all around half the amounts of those things. And then, when we're thinking about fries, if you were to just get the frozen fries and put it on a pan, that is going to have 220 calories, 10 grams of fat and 1 gram of saturated fat. Something that you could make instead of that are brown rice and frozen broccoli. So when we're thinking about our vegetables, typically fresh is what we say is best, but frozen is a really good option compared to canned vegetables. And the reason for that is that they don't add nearly as much sodium as in frozen foods that are in canned foods. So, kind of similarly to what you would, if you had a sheet pan and you put the frozen French fries on the sheet pan, you could do the same thing with the broccoli and put whatever spices and things you wanted on it. And then that would be a good alternative that would also give you fiber and good nutrients and things like that. So I think it is helpful sometimes to just have a comparison of your different foods from different places. So, something that I always say is, let me just stop. Something that I always say is, it's a process. We would never expect you to go from night to day. I think something that can be helpful is just taking it one day at a time or 1 week at a time. And you know, maybe this next week, if you're at a fast food restaurant, choose the side salad, choose the fruit cup instead of the fries. And I think that's an awesome adjustment. You know, a little bit of change goes a long way in the trajectory of your life. So I know it can be overwhelming with foods and nutrition, but small changes definitely can go a long way. So that is what I have for you guys. So I'll give it back to you, Dr. Russell.
Awesome. Thanks so much for the practical points. I love to see the differences that you put side by side. Guess I have to choose the vegetables instead of the fries next time. All right, now we are very lucky to have Dr. Teresa Oh, who completed her medical degree from Emory University Hospital and is one of our pediatric gastroenterologists at Children's Healthcare of Atlanta. And she's going to give us an overview of some differences in pancreatitis between kids and adults, and also share about the impact of living with pediatric pancreatitis. Dr. Oh, thanks for joining us.
Thank you so much. I'm very happy to be here. Let me just share my screen. So my name is Teresa Oh. I am a pediatric gastroenterologist at Emory and Children's Healthcare of Atlanta. We serve all of the children of Georgia, as well as some of the surrounding states. And we take care of kids as young as newborns, from neonates, all the way through 21-year-old young adults. And so as a pediatrician, I think we all take an incredible amount of joy in being able to be a part of our patients and our families' lives from the moment they're born. And we watch them grow through all of their developmental milestones and into their young adulthood. And that's particularly true, I think, of our patients who have chronic diseases, who need long-term care, and pancreatitis can certainly be one of those diseases. So this is the location that we will soon be practicing out of, opening later this year. And the need for such a location is very prevalent because the amount of patients that we see, the number increases every year. But so far we've seen over 400,000 children, which I think is an incredible number. And out of that, you know, our division, of course, sees all of the GI related diseases that affect our children. And for pancreatitis, even though initially it was thought to be very rare in children just a couple of decades ago, over the course of the last few decades, we realized that the incidence of pancreatitis actually reaches that even of adults. And so there's quite a lot of volume. And of course, our entire population, because we treat children, our entire population, we consider them to be of the vulnerable population, and particularly so if they belong to a minority group, and also of different socioeconomic statuses. And we see more than half of our patients and families are on Medicaid. So for kids, the causes of pancreatitis are actually a lot more varied than in adults. There's different types of pancreatitis, just as Dr. Russell had mentioned earlier, but depending on the types, there's different etiologies or different factors that can predispose a child to developing pancreatitis or recurrent pancreatitis or chronic pancreatitis. But in all of these graphs, the least prevalent causes are environmental. So we really don't see kids who develop pancreatitis because of alcohol or smoking, which is a large portion of the adult population. Rather, in kids, it's more a genetic effect, sometimes an anatomic effect, medications, and other reasons. The treatment and management of pediatric pancreatitis is actually pretty similar to adults. You know, if there's a lack of robust research in adult pancreatitis, you can imagine there's even less so in pediatric pancreatitis. And unfortunately, there's not really a single, a single treatment for pancreatitis. It's really all supportive, just like Dr. Russell had mentioned earlier. It's about good pain treatments. It's about providing enough hydration. It's about providing early feedings and good nutrition. Thankfully, in kids, the outcome of acute pancreatitis is generally good. And fortunately, pancreatic cancer is not really something that we see in children. It's very, very rare. But the up to a third of acute pancreatitis can recur. And so that's quite a lot. And of those, in a span of 2 to 5 years, that can progress into chronic pancreatitis. And although 2 to 5 years in an adult may not be that long of a time, in a child who is, let's say, 9 years old, 3 years of suffering from pancreatitis can be up to a third of their life. So that's quite a lot. And I think there was a question earlier that asked, are there any differences in the symptoms of pancreatitis in kids versus adults? Not really. It's all about the same. It's mostly belly pain. You can have yellowing of the skin or the eyes if you have certain causes like blockages. However, a lot of the symptoms are very non-specific. So they can be things like nausea, vomiting, poor appetite, and depending on the age of the child, if they're younger or if they're developmentally delayed, because the symptoms are so nonspecific, it can be harder to diagnose in kids. So they may not be able to tell you what it is that's hurting them. Sometimes we see kids come in just crying and not eating. And so you can imagine sometimes it's a little bit more difficult to actually diagnose the pancreatitis. And in kids, although the outcome is generally not, there's less mortality, there's less morbidity in kids than in adults, because it affects such a critical point in their lives where they're trying to meet their developmental milestones, or they're undergoing phases of growth, which is not something you can get back later on. You have to be more cognizant of nutritional deficiencies, as well as development of other consequences like diabetes and pancreatic insufficiency. So even though the complication risk and the mortality risk of pancreatitis in kids is not as high as that of the adult counterparts, the burden of the disease, the impact of it, I think still remains quite high. And I can tell you a story. There's many patient stories that I can share, but the way that it affects a child when they suffer from pancreatitis can affect them in all parts of their lives. So one of the patients that we've taken care of with chronic pancreatitis, she's a teenager who is a twin. So she has a sister who did not have pancreatitis. And so this patient, she came in as a teenager who had no health issues prior to developing this first time pancreatitis. But it was such a severe pancreatitis that she developed fluid collections, her body was inflamed, and she required hospitalization for about 5 to 6 months. And so you can imagine that's half of a year where she's missing school, where she's staying in the hospital, and even afterwards having to come back for multiple emergency department visits, undergoing treatments, seeing all kinds of medications, including pain medications. And so the development of anxiety and depression is highly prevalent in kids who suffer from pancreatitis, just like her. So, thankfully, we have a dedicated pancreas clinic that's multidisciplinary. It includes pediatric gastroenterologists like myself, as well as psychologists, pain medicine specialists, dietitians, and so forth. And so we all sort of work together to take care of patients like this teenager that we saw. And eventually she was able to overcome her pancreatitis without really needing more aggressive surgery other than taking out her gallbladder. But there are many stories like that. And so I guess I also want to put in a little plug for something called Camp Hope, which is put on by this foundation as well as Rebecca's Wish. This is something that I learned of myself, that I first learned of in one of the fellows conferences that this foundation helps put on every year. And it's a camp that allows children who have suffered from pancreatitis, who are suffering from it, who have had to undergo surgeries because of it, to help them kind of come together, be with other children that have gone through the same thing, help normalize some of the things that they have gone through, and be able to be kids again. And that's so important because, you know, this is a part of a point in their lives when they're undergoing so many different changes, and the feeling of being different is particularly, you know, it's very, very it can be very disheartening to them. Really, they just want to be like everybody else. And so for the teenager that whose story I shared earlier, especially the fact that she's a twin with her sister not undergoing any of the things that she had to undergo, really highlighted the feeling of being different. And so socially, that can be very distancing. And so this is a great program, Camp Hope, where they can come together and be with kids like themselves. So that's kind of what I had to share there. And of course, I'm also happy to take questions later on as well.
Sorry, I was muted. Thanks, Dr. O. That's a fantastic talk, and gives some insight into a process that a lot of us are less familiar with. So thanks for all the work that you do for all the children. Well, there's some questions, but I want to introduce Mr. Thomas Walters, who is a pancreatic cancer survivor, and he's going to share some words with us. Mr. Walters?
All right, good afternoon, everyone. First of all, I'm an African-American male who have never smoked or drink very rarely. And I am a pancreatic cancer survivor. My journey was that I one day started feeling a little different with my body. I wasn't in a lot of pain, but when I went to the bathroom, I noticed some things that was happening that was unusual. So as that progressed, after maybe a couple of weeks or so at the most, I just decided to go to the emergency room. And when I got there, they immediately started doing a lot of tests, and I was admitted immediately into the hospital. And then later, in being there, I was told that I was diagnosed with pancreatic cancer. Well, of course, it was a shock to me because even though I kind of prepared for that, the possibility that, could get cancer, because that is something that is rapidly growing within the African-American community, I didn't ever think that I would get it. But I did. And it was, I wouldn't say it was it was surprising, but, just through my faith and confidence, I felt like, if I learned about what was going on and did what I needed to do, on my part that, hopefully that, we can beat this. When I read up on pancreatic cancer, I did see that, it was a devastating cancer that, there are, many that don't survive it. And of course, I had, heard of others who didn't. It was funny because it seemed that after I got diagnosed, I kept seeing all these commercials related to cancer, particularly with the Cancer Treatment of America, which is now City of Hope. So I began to do research in terms of the surgery itself. And I actually went to the Cancer Treatment of America to just kind of see, what they were offering as relates to um, the treatment of my pancreatic, surgery and all. And they pretty much told me that, what they were offering was the same treatment that, was already recommended. Well, it was just up to me at that point in terms of what hospital I wanted to go to and what doctor I wanted to have to do the surgery. And one of the things that really convinced me, I am a patient at Grady. Every time the name of Dr. Russel came up, or someone, one of the health professionals, nurse, whoever, would see Dr. Russell's name, he said, "Oh, she's a good doctor. She's great. You're gonna love her," and all. So, actually, because of the high recommendation that I received, then I decided to, stay at Grady and have my surgery done there. And I'm very pleased that I did so, because I'm happy to say that at this point I am a cancer survivor and the surgery was successful. Part of what helped me was the confidence that Dr. Russell had and her knowledge as relates to, explaining, the procedures and all, because, there's a level of fear and uncertainty as to what is going to happen. And, sometimes even cross your mind, am I going to survive this? And, how's my life going to be afterwards? But, for some reason, every time Dr. Russell came into the room, it just kind of brightened up my day because of the presence of her just confidence and being a caring person. So that helped me, a lot in terms of this journey. So I still, I guess my biggest challenge was the chemo part. And I must admit that I was one of those individuals that was reluctant as relates to chemo, particularly after the surgery, because I didn't understand that if I had already received the Whipple surgery, why was necessary for additional chemo, because of course it has its own effects and discomfort. So, of course, I'm an oncologist. Talked to me about, the importance that I really need to get it. And then, of course, once again, Dr. Russell came and, shared with me and the importance of me, having it. So I did do that. The only thing I'm glad I did, but the side effect of that is dealing with neuropathy. So that was something I didn't expect. So I would just say that I have maybe, I guess, 5 suggestions as a survivor that perhaps will maybe help someone else. And some of these things, of course, have already been shared by the previous doctors who have spoke this afternoon. One is that try to eat right and have a good and healthy diet. And I can't say that I always do that, but I'm getting there and doing better. If something is not feeling right in your body, and you know it's something out of the norm, I suggest that you immediately go and go to a doctor to see exactly what's going on. It is important to go to get things checked out versus just letting it just linger and thinking, you're trying to do your own self-diagnosis. That's not good. And also remember that, as has been said, the early detection can help as relates to you being able to, the doctors being able to help in finding a way to make you a survivor, with this, with cancer. And try to, of course, get a good doctor that you can relate to, that you can work together as a team, and you doing what you're supposed to do, and allow them to, do what they do, and together it helps in terms of you getting back to reasonable health. And that is what has helped me. And finally, if there's medicines too that is prescribed to you, to make sure that you take your medicines as well, along with the good diet. So I'm happy to say that I'm a survivor. I have been a part of various groups and organizations that I now can share my story, and also just the journey for others to kind of think about and answer questions that they may have if they are diagnosed with cancer. So that's my story.
Thanks so much, Mr. Walters. Always inspirational to hear from you and your journey, and just so proud that we could walk a little bit together with your journey. I'm going to ask all the speakers to turn back on their cameras. There's some questions in the chat. I don't think we have a chance to answer all of them. I do think that one I'm going to address to Dr. Page. There's a question about a second opinion. And as a patient, as a physician, what do you recommend for your patients when they say that they want a second opinion, and how should the patients address that?
Yeah, great question. I saw that, and I was, I'm honored to obviously be on this panel. Thanks, Dr. Russell. So the second opinion question, I'm a huge fan of second opinions. When a patient comes to me and they say, do you think I should get a second opinion? I say, if you were thinking about a second opinion, get a second opinion. I cannot reinforce that enough. Now, does everyone think that? Absolutely not. My only concerns about second opinions are, and I don't want to speak for Dr. Russell, but I think it's very reasonable to ask myself or Dr. Russell, who should I see for that second opinion? Because sometimes you can get a referral to a second or third opinion where it's not someone who you think should be taking care of that type of problem or that type of cancer in my case. The second component of getting a second opinion is, I see this happen probably 2 or 3 times a year, is that the workup and the logistics of getting into that second opinion can delay your care. That bothers the stew out of me when you go in and hey, well, Dr. Page, I'm coming back to see you now. I saw my second opinion. It's been like 2 months. That second opinion needs to happen with pancreas cancer, or I think really any type of cancer. It needs to happen quickly. But the key is you've got to be comfortable with your team. And if you're not, absolutely get a second opinion. I have sometimes been a little bit too aggressive when recommending patients get second opinions. I've had that happen a few times, but don't hesitate to get a second opinion. I think getting a third and fourth opinion is a little overkill. But if you need one second opinion, I've been there with my family. I always don't hesitate to get a second opinion. But that's a little bit opinionated on my end, so I defer to Dr. Russell if she wants to throw down with me.
Couldn't agree more. I recommend a second opinion wholeheartedly, and agree with everything that you said. I think it's really important. It's a big decision. It's your life. And if you feel very comfortable with the person and they are at a good institution that performs, a fair amount of pancreas surgery. I think there's a question in the chat about knowing how many numbers that the surgeon or the hospital does. The newest numbers for hospital are low volume is less than 9 pancreatectomies a year, medium is 9 to 35, and greater than 35 is considered high volume. That's not surgeon specific, that's institution specific. So, so there you have the numbers. Whitney, I'm going to ask you real quick, is there an app or a food journal that you recommend for patients to keep track of their eating or calories?
So I know a lot of people will use like MyFitnessPal. That's a free app that is super helpful just because it has pretty much everything on there. That is the one that I probably have most people on just because of ease of like using it. But I mean, any kind of, journal that has things on there is helpful, but that's probably the one that I hear about the most from people.
Great, thanks. Dr. O, is there any screening that's recommended? Familial pancreatitis is a big one. Is there any screening that you guys use, or how do you diagnose the pediatric pancreatitis? It seems to be a little bit of you just have to have some type of clue that it's going on. How does a patient get from their primary care doctor in rural Georgia to CHOA?
So it sort of depends on what type of pancreatitis you have. So if it's their first time, then we have a saying that everybody gets one free pancreatitis. So we don't necessarily pull out all the big gun genetic testing if it's their very first bout of an inflamed pancreas. And in that case, we really just use an ultrasound to look at the pancreas. We look at some of the markers in their blood, enzyme markers in the blood, and we treat them supportively. Now, if they come back again with another episode, and sometimes I've seen kids have 8+ episodes of pancreatitis within a single year, that then lets us know there's something else going on, whether it's genetic or whether it's further imaging that we need with an MRI. And so that's when we start doing further screening with genetic testing, and there are certain blood panels that we can look at, as well as other images and ERCPs and things like that.
Great. Thank you. And one final question, Mr. Walters, how can friends and family help? How can they support their loved ones when they're diagnosed with pancreas cancer?
Well, I think that's very important. One is to kind of listen to the patient, the family member who are going through their cancer journey. And, there are days that you're not feeling well, you may be irritable, may have pain or whatever, and let them tell you what they need. And just try to be there, for them. It's important. I always try to have, someone with me, because a lot of times when you go to the doctor and they're telling you things, I mean, you hear it, but then you're thinking, other things. And I, would have, a friend or family member that would go to appointments, with me, so that, later on they can maybe remind me, well, Dr. Russell suggested this, or, whoever your doctor is. And you can just kind of help to be their, support team, to, remind them of things that they, need to do, things that they need to remember, because, everybody, and having cancer deal with it differently. So you have to, just kind of be, patient and supportive of them, in terms of, the different ways that they may be, dealing with it, and just being there for them.
Fantastic advice. Thank you. And I just want to thank all of our panelists. Thank you so much for spending time on a Saturday morning with us. I'd like to thank the National Pancreas Foundation for having all of us, the John R. Lewis Legacy Institute as well. Just a reminder, the email up there, if you have any questions, please feel free to email us. And this webinar will actually be posted on YouTube later on this week. I hope everyone has a wonderful rest of their weekend, and thanks again.
Thanks, Dr. Russell.
Thank you.